Okay, this video is what are the best and worst radiology subspecialties. Okay, so first of all, why did I go into radiology? At the time I was a medical student, I was a great medical student, first in my class, and I knew I had an encyclopedic memory. I knew I could memorize stuff as well as anybody in the whole country. By the way, I took my radiology boards, like 4.5 hour tests. I was done in an hour and 10 minutes with a perfect score. So I just figured in radiology, that type of memory for medical information would be good for me. So I like that. Also, you get buyer's remorse. After you studied everything in med school, you hate to give up so many different things. You've rotated through all these different specialties. So I felt in radiology I could keep in touch with all the different specialties. And, I wanted to do procedures, but I knew my personality. I'm a total workaholic. If I went into, one of the like surgical subspecialties, there were typical ones, I would be working all the time. I would never do anything else. So I figured in radiology I'd probably be able to balance my life and I could do interventional radiology, which is imaging guided surgery, and still have a balanced life, some time for family, that sort of thing. Okay, so I did go into radiology and I initially did fellowship in interventional radiology at Harvard, and then I then moved over to neuroradiology. I had kind of always wanted neuroradiology because I love learning about the brain, but I didn't like doing all these spines, especially post-op spines. So anyways, that's how I ended up in radiology instead of ortho, where there was too much blood aerosolized all over the place, and I was afraid everyone was afraid you'd end up getting AIDS if you went into that. I got talked out of plastic surgery by my dad and his friends. And then cardiology, I went and I rotated through it, and I just didn't like it that much. I thought I was going to like it, but I just didn't. Okay, so anyways, what are the best and worst radiology specialties? First of all, we'll talk about MSK. That means musculoskeletal. Musculoskeletal is very popular subspecialty radiology. A lot of women go into it, and I think that's because they feel they can maintain a balanced lifestyle and they like it. The reason for that is there's not that many emergencies in musculoskeletal radiology. Okay, there's certainly not that many that require you to go into the hospital. It requires a lot of knowledge. There's a lot to learn. So I actually find myself often having to talk to a musculoskeletal radiologist. Like one of the things I have to do a little bit of is read plain films. I don't read a lot of plain films, but when I do read plain films, there's all kinds of weird musculoskeletal things that happen, and it's nice to call them. So their expertise is highly valued. Joint MRI is pleasant, reading shoulders and knees and hips and all that, but it's kind of complex, especially the shoulders and the ankles. But that gives them something to do and to be experts about. Okay, what's bad about MSK? I always thought it was kind of boring, I care about the brain. Everybody needs their brain to work as well as possible. It's not that exciting to me, bone broke must fix, a little bit like an ortho mentality. Some of this MSK radiology, I'd be bored out of my mind, just looking at ankles all the time and stuff. So that's why I didn't ever consider it even to go into MSK radiology. But like I said, it's very popular with a lot of people, especially women. Neuroradiology. The brain's the most interesting thing in the whole world. I mean, it's just fascinating. And I would constantly find myself interested in things in the brain. Plus, the background I was coming from was I had been interested a lot in study skills, cognitive optimization, memory techniques. So looking at brain MRIs, I was always talking about the brain to people. It just was a natural thing to do, is look at brains. And I liked sort of the intellectual personality of a lot of the neuroradiologists. They tend to be, amongst the smartest radiologists. And so that sounded to me like, well, I'm going to have to work a lot. I might as well study something I'm interested in, is looking at the brain. Because a lot of people, they don't like their jobs and they sort of just, go through the motions all day long to collect a paycheck. And that's it. You trade your time for money. And so with the brain, though, I was rather fascinated. And I found myself very commonly wanting to look stuff up. I also, because I knew a lot about the brain already. My father was a psychiatrist. I already read extensively about the brain. And I was interested. I had all these ideas and theories about stuff in the brain. So then I would see these cases, all these strokes, all these demented patients, and it was very motivating for me to try to really understand atherosclerosis, diabetes, hypertension. And the way you really understand something is you say to yourself, what causes atherosclerosis? And then you start reading about it. And then I kept discovering one thing after another. All the textbooks are a joke for atherosclerosis. They're a joke for diabetes. They're a joke for hypertension. So there's plenty to do reading about these things. And I became fascinated by the eye because the human eye is basically like a miniature brain. It's part of the central nervous system. And you could see it. Things you can see in the eye, lots of them happen in the brain. So I became fascinated with reading about the eye as a way to understand the brain. So anyways, neuroradiology, studying the brain, gave me a lot to think about and do. And there's a lot of real smart neuroradiologists. And so when we get an interesting case, we talk to each other. And we'll talk to each other. We can see that we have a way to see the cases through a computer system. And we'll just talk to each other about the cases. And I find that very interesting. A lot of times it's the highlight of my day. Plus, also, a lot of doctors come by to talk to me, even if it's not neuroradiology. You know, they know I'm really smart. They'll come by, they'll bring me all kinds of weird cases get shown to me, including outside my field. And so I kind of like that. It's very intellectual. I'm going to talk about interventional radiology in a moment and how that's very different. It's not that intellectual, but it's complex. I mean, there's a lot to do in interventional radiology. Interventional radiology is like probably one of the most popular things in all of medicine, yet alone in radiology. I'm going to go into that in some detail here at the end. Okay, what's bad about being a neuroradiologist? Lots of emergencies in the afternoon. It's sort of like all these patients will have minor complications all over the place, the hospital, at home, or whatever, and then they all funnel towards the emergency room and towards getting lots of CAT scans late in the day. So it's pretty routine for a neuroradiologist to have had a reasonable day, gotten caught up on all their elective outpatient MRIs and stuff, and then in the afternoon, patient fell, head CT, rule out bleed. Patient fell, patient on blood thinners, okay? Patient dizzy, patient headache, patient demented, okay? Acute stroke, stroke protocol, CTA, head and neck. That goes on and on. Acute stroke, MRI brain. So you get lots of emergencies, and you got to really crank through a bunch of simultaneous emergencies in the afternoon. So that can be kind of stressful. Plus, you know, for a neuroradiologist, theoretically, you might be told your shift ends at such and such a time, but there could be 5 emergencies in the last 10 minutes, and you got to stick around and read all of them. So it's a lot of work, and it's under stressful emergency conditions. I'm so used to doing it. I do it all the time, but it's no walk in the park. Okay, the other thing about neuro that I don't like so much is all these post-op spines. There's a lot of train wreck post-surgical spines, and they can be real complicated to read. They got surgical hardware at every level, tons of artifacts. And so, it's part of the job. Any job, you got to take the good with the bad. But that would be the bad part. That's why I initially didn't go into neuro. I'm like, I don't want to spend my time looking at all these post-op spines. I want to do IR, all these cool procedures. Anyways, okay, mammography. Now, mammography is actually popular with a lot of young radiology residents. And the biggest reason is you get great hours. It's all elective, daytime work. You go home. There's a lot of risk of lawsuits, so that's bad. The other thing is I hated it because I thought it was incredibly boring. It's like looking at a picture of the moon, just this plain film x-ray looking for calcifications, and the women are all freaked out. It requires good social skills. When I was, my social skills have gotten better with time. I'm an old man now. I've raised a family. I've been through all this stuff. But when I was a young guy, I didn't really have that good of social skills. And all these women are crying. They're afraid they have cancer. They all think they have cancer, okay? And almost none of them do. And so then I would have to go in the room as a resident and talk to this lady. She's crying and all this stuff. And I'm like, I was not the guy to do that, all right? That was one of my weaknesses when I was younger. I just didn't have that good of social skills. I wasn't able to empathize that well. After being married, raising a bunch of kids, also just dealing with life as one gets older. And I actually spent a lot of time trying to improve my social skills. I read everything I could to try to learn how to improve my social skills. All these books about body language, conversation, all this stuff. Because I kind of needed it, from where I'd been coming from. So anyways, what I'm saying is if you want to go to mammography, you got to have really good social skills. And you have to want to do that. I think mammography is kind of bogus. It's overrated. There's a lot of people who think that it shouldn't even be done at all in women, unless they've got a palpable mass, and especially if they're less than 40, and especially too if they're less than 50. So I didn't get a sense of achievement with it. And other things I thought were funny was I can remember in my residency, I did my residency at Northwestern. I wanted to go to Harvard, but I stayed in the Chicago area because my mom was dying of cancer. I always felt like being at Northwestern was like being in kindergarten for me. I belonged at Harvard. So, but anyways, be that as it may, what I thought was funny was we had these academic mammographers, okay, who could analyze every single thing ever known in the history of mammography, and they wouldn't read that many cases. And then we had these other mammography lady who was like the most unacademic lady, but she would read like 4 times as many cases as all the other ones. So that was funny too. You didn't need to be academic to read them. All the referral surgeons and stuff, sort of hated that fast lady, and they liked the academic ladies. But it was the fast lady, the one who could read real fast, that got all the cases done. So that was funny. Okay, body radiology. Every radiologist already knows body imaging, which basically means imaging of the abdomen and the pelvis and the chest. It also includes ultrasound. So regular radiologist already knows all that. So there's really no marketability for them unless they do something extra. So a lot of them, will find some niche. Like a common niche might be to do prostate MRI or to do cardiac imaging or something like that, or to get really good with some of the little details of, pancreas imaging and all that. But I don't know. For me, that was all pretty boring. I've read so many body CTs. It's like painfully boring. Many, 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 many thousands of them. Okay, so one radiologist told me he almost wants to vomit when he has to read a body CT because you read so many of them, it gets boring. Okay, ultrasound. Ultrasound's nice, but it's not that aesthetically appealing, and every radiologist already knows how to do ultrasound. And you talk to a private practice radiologist, they'll tell you we just go by whatever the technologist tells us 9 times out of 10. So don't get me wrong, I like ultrasound, but it's not that intellectually exciting. It's binary. Is there a tumor in the liver? Yes or no. Is there hydronephrosis of the kidney? Yes or no. Okay. The worst thing in ultrasound is the obstetric. A lot of med-mal-pral risk. Plus, it's kind of complex. Unless you're really interested in that, you'd have to be probably at a big university. Actually, at most places, the OB-GYN doctors have taken it over. But at some smaller places, it's still done, the OB ultrasound by radiology department. So it depends on your place, but I never was too interested in that. As a young guy, I was used to taking care of adults. Kids were like little outer space aliens. I didn't want anything to do with pediatric radiology or OB radiology. Oh, pediatric radiology, by the way, is also an important subspecialty. So, the best place for that is if you work at a pediatric hospital or maybe some big university where the peds is mixed in. But I never had any interest for pediatric radiology. A lot of women go into that. Women know more about children than men do. We're kind of like separate from the world of children to a large extent. It's just reality. I always thought of kids, like I said, as little outer space aliens. Their anatomy is different. You have to know all this embryology. It's this whole other world. A lot of pediatric radiologists I met are very smart and they know a lot, but it's sort of like, I take care of adults. Why do I want to learn all this other stuff? I didn't want to. Chest radiology. There's nothing to do in chest radiology. All the radiologists already know chest radiology. The only difference would be if they do cardiac imaging. Okay, nuclear medicine. There's more to do intellectually if they also read PET scans, positron emission tomography. That's the stuff for cancer imaging with fluorodeoxyglucose. They have good hours, probably have the best hours of any subspecialty of all of radiology. It's not that difficult. This is maybe the best lifestyle radiology, especially that and mammography. They can potentially have emergencies with VQ scans, for example, with hepatobiliary scans, HIDA scans for looking for acute cholecystitis of the gallbladder. There's not that many jobs. Like most radiology departments will have tons of radiologists for all these other areas, not too many nuclear medicine specialists. Okay, now we're going to talk about interventional radiology. I think this is a topic that most people are going to find most interesting. So IR means interventional radiology. And why is it so popular? It's one of the most popular fields in all of medicine right now. And I think that's because you can't outsource it, meaning that you can do a lot of other radiology specialties to a large degree through teleradiology, over the internet. But you can't really outsource interventional radiology, especially not the big cases. Those smaller cases like, putting in PICC lines, those are being progressively taken over by PICC line nurses. And a lot of even interventional radiology departments have physician assistants and nurse practitioners that do what you might call some of the easier procedures. Like they might do a thoracentesis, for example. Maybe they're going to do routine dialysis catheters, especially on the right side. It's a little trickier to do a dialysis catheter on the left side. So I think people are liking it because there's good job security. It's also, kind of prestigious. People tend to have a lot of respect for an interventional radiologist. They know it's a tough job. What I liked best about it, it was really social. Every day when you're an interventional radiologist, you've always got a bunch of residents around. You've got nurses. You've got Doctors from other fields always come by to talk to you. You make rounds on the floor, so you know all the nurses and clerks and lots of doctors from other fields on the floor. They're all nice to you because they know they're going to need you to do them favors. There's all kinds of patients that are train wrecks and a mess, and they want to be your friend because you can help them out of a lot of situations. So when I was an interventional radiologist, I knew tons of doctors, nurses, techs, clerks from all over the hospital. I had a lot of fun. I talked to a lot of patients. I liked my patients too. So it was fun. It was socially very fulfilling. That's the biggest thing I miss about it because I don't do that much IR anymore. I do a little bit, but not that much. I mean, I still do a lot of biopsies. I'll do myelograms, lumbar punctures, and stuff like that. But it's no longer, I used to be doing all these big interventional cases. So that's the most big thing I miss. I used to go to work and it would be real social. I'd be talking to a lot of people all day long and then doing surgeries. And I like that. Whereas now, I'll say hello to one secretary and then I sit in a room, read all these complex brain MRIs, spines, necks, all this stuff. And I talk on the phone and, doctors come by, have me go over cases. I still do some procedures, but it's much more socially isolated what I do now. I could easily go a week and not speak to a single female other than say hi to a secretary when I walk in the door. So the part I enjoy best is analyzing complex brain cases with my fellow doctors, mostly a bunch of guys that were all real interested in the brain. The fascinating conversations. I mean, we learn all kinds of interesting things, and neuro conferences are fascinating. We go into great detail about all these nuances of the brain and the pathophysiology of dementia and preventing dementia, which is sort of preventing all disease because everything that damages bodily tissues quite often ends up damaging brain tissue as well, like autoimmune diseases, like multiple sclerosis, okay? Hypertension damages everything in the body, and diabetes, those are like the most common reasons people are dying, and atherosclerosis in the brain, they're paramount. So anyways, what else about IR was good? You often see patients really get better. Patient has hydronephrosis, means blockage of the kidney, but let's say by kidney stone or a tumor, you put in a nephrostomy tube in, the kidney works again. So that's fulfilling. You have a patient on a ventilator with an abscess, you do a CAT scan guided abscess drainage. I used to do tons of those. I did many hundreds and hundreds of those, and I used to like it. I'd see patients come off the ventilator. I used to put in tons of chest tubes, and I'd see a lot of patients really improve well. I used to do thrombolysis with chest tubes, all kinds of stuff. So that was fulfilling. A lot of patients do get better, have real improvements. The technical stuff of doing ultrasound guided venous access and biopsies is a big advance over what used to be the case. When I was a surgery intern, we used to have to put in central lines. Let's say we were going to go into the jugular vein. And, I was, as the intern, I just had to do the senior resident set. And I would have to hold down these demented patients, and they would just be doing palpation landmarks. And it was kind of a miserable business. I didn't really like the palpation landmarks for putting in all these central lines. Versus an ultrasound with imaging guidance, it's a walk in the park to obtain venous access. So it was a giant improvement, and ultrasound guided biopsies are very nice in comparison with other techniques. You use CT when you have to, but it's much nicer to do stuff with ultrasound when you can, or fluoroscopy sometimes for some stuff. But I prefer ultrasound whenever possible. It's always the best way if it's doable because it's fast, it works, it's good. You can see your needle go into the mass. Okay, what is bad about interventional radiology? Why was I willing to leave interventional radiology? Well, first of all, radiation exposure. And I can tell you that's why you'll almost never see a woman go in interventional radiology because during her whole pregnancy, 9 months, if she's doing interventional, she's going to be exposed to some radiation. And then when she wants to, she's going to need to take time off and breastfeed, and she's going to want more time off. So she might have to be off a year and a half. And that's a long time to be off from a job, and especially if you have partners in private practice or something. You're always walking around in lead, and some people get back pain from that. But the case volume is changing in interventional radiology. There used to be tons of venous access PICC lines. I put in thousands of PICC lines. I probably put in like 3,000 PICC lines, all right? Whereas nowadays, most of that stuff's done by nurses, the PICC nurses. Only the difficult cases go to IR. The IR docs are doing more and more difficult cases, things like declots of dialysis grafts that are thrombosed. And I hated those cases because there's a risk of getting radiation to your brain. So I basically got out of interventional radiology before radiation exposure started going up. Back when I was in it, there was very little. And I like that. I don't want radiation exposure. Whereas nowadays, it's significantly increased at most places. It'll depend on the practice volume, but in most places, they're doing a lot of declots. They're doing a lot of long, complex embolization cases. Typical embolization cases are things like transcatheter embolization, of the hepatic artery for these liver cancers, hepatocellular carcinomas. They'll call them TACE, transcatheter arterial chemoembolization. Some places doing a lot of TIPS, transjugular intrahepatic portosystemic shunts and stents, going through the right eye, down into the heart, implanting an artificial blood vessel in these end-stage cirrhotic patients. And I used to kind of hate those cases. When I was young, I thought they were a little bit interesting, but the more time went by, I hated those cases because they're really long, complex cases in general with a lot of follow-up, and the stents often don't stay open that long. They're high maintenance. A lot of transplant work can be real high maintenance for an interventional radiologist. I remember when I was in residency, like one interventional radiologist was all happy because they were going to start doing a lot more transplants at the hospital. This was at Northwestern. And then the other interventional radiologist was, you don't understand, we're going to now have to be coming in on call all the time because everybody's always freaked out about a transplant. We must immediately intervene, otherwise we could lose a transplant. So tons and tons of emergency transplant cases. So I didn't like that. Like I said, the case volume in IR is switching towards more of the long, hard, higher radiation type cases. So all that I didn't like. A lot of the easy stuff, PICC lines. And you might think PICC lines are boring. I had a neuroradiology friend say, why would I want to start all the IVs in the hospital? And he meant putting in PICC lines. But after you've done a lot of them, I could do them so fast that I was quite happy to just do a bunch of PICC lines. It was like a Zen thing. It's just a walk in the park. They're so easy and fast. So I was quite happy to do them. There's turf issues in interventional radiology. Pretty much anything that can be taken away from interventional radiology that's desirable gets taken away. The vascular surgeons got pissed off that they were doing all the peripheral vascular stenting, so they took over. They took that over because they control the referrals. Whoever controls the referrals can control who the patient's referred to. I also saw weird things that would happen in interventional radiology, and it totally depends where you're at. If you're at a university, most doctors are on a salary, and they just sort of do whatever they have to do. But if you're in private practice where they're getting on a fee-for-service payment, you get all kinds of weird situations. So at a university, everybody was happy to dump more work on the IR doctor, okay? I was in private practice, and then I got a phone call from a nurse. I had to put in a suprapubic cystostomy. That means a bladder drainage catheter over the pubic symphysis and through the pelvis. And so she says, well, the patient's down there. Can you throw in a PICC line? He needs it for antibiotics. I'm like, yeah, sure. So the guy comes down, I throw in a PICC line. Then I get a phone call, and I'm told that, the general surgeon who is upset, who's also taking care of that patient, that I stole his PICC line. I'm like, what are you talking about? The nurse asked me to do it. But he's like, he does the venous access at that hospital. And so for me, that was when I was a new young guy. I'm like, okay, you can have it. But what I'm saying is IR often finds itself in weird turf situations like that. But what was the worst thing about IR? First of all, you're on call all the time. When I started out, I was on call every other night, and I was even on backup call on the nights when I wasn't really supposed to be on call. So I work long hours. You do get paid well, but you're going to work long hours. And you also get forced to do a lot of stupid cases. There's a lot of cases where there's really no point in doing anything, but there's tremendous pressure on the interventional radiologist. A lot of times this would be end-stage cancer patients, where the best thing to do for the poor person is leave them alone. But what would happen is the family would demand something's done, and all the other services knew that there was nothing that could be useful that could be done for these patients. So they would just pressure IR to do something, whatever it might be, and it would be almost kind of stupid, But the IR doc has to do those cases. You say, well, why do they have to do it? Because if they don't, they'll get in big trouble. The other service would say, how come you're refusing to do the case? And so, if an IR doc refuses to do a case and the other services feel they really want it done, they'll call the IR doc's supervisor of their department, whoever that might be, and the IR doc will be forced to do the case. Believe me, I have a lot of experience with this. So you would have to do stuff that you would think is stupid. We already know what the patient has. Why do I need to do another biopsy? Why do I have to do this? But so I didn't like that because, like a general surgeon, you don't tell a general surgeon you have to operate on appendicitis. The general surgeon will say, obtain a consult, I'll review the case, and I'll make a decision about that. Versus an IR, you would often get very heavily pressured to do cases that you didn't want to do. So I didn't like that. And then being on call all the time and working long hours, it was very difficult to have a predictable social life. I mean, on the one hand, you could weasel out of stuff in your family. Nope, I can't drive the kids anywhere because I'm always on call. Even when I'm not on call, I'm on backup call. So I can never be in charge of driving family members, ever. And so that might be a nice way to weasel out of that if you want. But what I didn't like was you can never do anything in a predictable fashion. Let's say I decide this morning I'm going to study something. I went through a phase where, when my mom died and I really wanted to study Spanish for a while just because it made me feel closer to my mother. And my Spanish had been okay, but it wasn't that good. And I wanted to get it good, okay, because that made me feel close to my mom at that time, for what that's worth. All right, so you would get called away, whatever you were trying to do. And also I had an idea. I wanted to write a book about, study skills many years ago. And when I was doing IR, I would keep getting called away from the work. You couldn't get long blocks of intellectual time. If you're going to do research, if you're going to write books, you need a long block of intellectual time to really study a subject, put it all together, and write about it and stuff. And you can't do that with IR. You're just on call. The phone's ringing. The pager's going off. You got to get yourself over to the hospital, do that case, do it on an emergency basis. So it's very common. There's just constant interruptions and emergencies for an IR doc. So don't get me wrong. You make a lot of money. You're highly respected. There is a lot of interesting stuff. But I think nowadays you're getting exposed to more and more radiation, which is not good. And like I said, I got out of it early. I never had a problem with any of that. But that's the direction it's going. So anyways, those are the best and worst of radiology subspecialties.